Welcome to the Nursing Post podcast, all nursing all the time with Ashley Moore and Rosa Horsley. In today's episode, we discuss hemophilia. Our goal is always to inform and start conversation.
A small cut or an accidental fall to most of us is not a big deal, but for those with hemophilia, it can become a matter of life or death. Hemophilia is a genetically inherited bleeding disorder where the blood does not clot properly. There are two types of hemophilia. Those people with hemophilia have type A, a mutation of factor VIII, or type B, a mutation in factor IX.
My favorite, statistics. We'll always love the numbers.
Yes.
I love it when it has cash signs by it, but I'll take numbers however I can get it. So hemophilia affects 1 in 5,000 male births. About 400 babies are born with hemophilia each year. 33,000 males in the United States are living with this disorder. Females may also have hemophilia. The median age at diagnosis is 36 months for people with mild hemophilia, 8 months for those with moderate hemophilia, and 1 month for those with severe hemophilia. In 2/3 of cases, there is a family history of hemophilia. In 1/3 of the babies born with hemophilia, the family has no known history of having hemophilia.
So this is pretty important, I think. If you have a family member that does have hemophilia, I'm sure that that's caught, the child that has it is probably caught more quickly because they understand their disease process a little bit better. But for the third that have no family history, especially if they don't know about the disease, this can really take a little bit more time.
Absolutely. And depending on the severity, we always talk about this stuff, and we're going to get into this in a little bit here. You're probably not thinking, oh, this is a long time. And in this case, it doesn't take a long time to get diagnosed. If you have severe hemophilia, you're going to know that within the month.
Right.
And we're fortunate enough to have the science which allows it. But if you have a very less severe form of it, 36 months is a long time.
Right. Especially if that's your child that's having problems.
And then you have no history.
Yep.
Yeah. So you're trying to figure things out. Why does he keep getting bruised every time
somebody touches him lightly or something? Sure.
So anyway.
So there are different causes. The X chromosome mutation is where the problem lies. Mothers are carriers of the disorder, but because females have 2 X chromosomes, they don't have the disorder. Males only have 1 X chromosome that they inherit from their mother. So they don't have another X chromosome to help with the mutation. For the mutation, low levels of either factor VIII or factor IX, the severity is determined by the amount of factor in the blood. So this is lab work. The mutation can be the protein needing clotting or be non-existent altogether. So for family history, there will be some families who have no family history at all. Like Rosa said, about 1/3, according to the CDC. For type A, which is the most common type of hemophilia, affecting about 80% of patients, the cause is a lack or decrease of the clotting factor VIII. And for type B, which is less common, affecting about 20%, it's caused by a lack or decrease of clotting factor IX.
So the signs and symptoms of hemophilia can range from increased bleeding after a trauma or injury or surgery to sudden bleeding with no apparent cause. And most children have bleeding within the first 18 months of life. Bleeding in the head of an infant after a difficult surgery, bleeding after circumcision, which, we know is, surgically performed on males to remove the hood of the skin, called the foreskin that covers the head of the penis. Bleeding after having shots such as vaccinations, having swollen, bruised joints or muscles when learning to walk, bleeding into joints spontaneously, or from just learning to walk. easily bruising from minor bumps, bleeding into the skin or muscle and soft tissue, causing it to build up in a particular area, which is called a hematoma. Frequent nosebleeds, gum bleeding after you brushed your teeth, and sometimes bloody urine or bloody stools.
For diagnosis and treatment, patients who have or have had family members with hemophilia will ask that their baby boys get tested soon after birth. So that's where you're going to be catching things even more quickly.
Absolutely.
Best case scenario is for testing to be planned before the baby's delivery so that the sample of blood can be drawn from the umbilical cord immediately after birth and tested to determine the level of clotting factors. So this is where communication is key.
Absolutely.
About a third of the babies who are diagnosed with hemophilia have no family history, like Rosa had said earlier. So a doctor might check for hemophilia if a newborn is showing certain signs of hemophilia, like the deep bruising after their routine vitamin K shots, bleeding for a long time after the infant's heel is pricked, bleeding that goes on for a long time after the baby is circumcised, and bleeding in the scalp or brain after a difficult delivery, or if special devices like a forceps or something like that was needed to help assist with delivery. When you are not an infant, the diagnosis comes from lab work. So this is usually a CBC, and this looks at the amount of hemoglobin, red blood cells, white blood cells, and platelets. With a CBC, it's typically normal in patients who have hemophilia, but if a person with hemophilia has unusually heavy bleeding or bleeds for a long time, then their red counts could be low.
Absolutely.
There's a test called an APTT. It's an activated partial thromboplastin time. This test measures how long it takes for blood to clot. And it measures the clotting ability of factors 8, 9, 11, and 12. There is a prothrombin time, which I think a lot of nurses are probably familiar with, a PT.
Absolutely.
And that also measures the time it takes for blood to clot. And it looks at factors 1, 2, 5, 7, and 10. So you can see how those two complement each other.
Absolutely.
The fibrinogen test is another name for a clotting factor. This helps doctors assess the patient's ability to form a clot. This test is ordered along with other blood work, such as an abnormal PT or APTT or both. So if there's strong suspicion, maybe they'll just go ahead and add it in. If not, they may add it on after an abnormal test has come back. And then another lab that they may do is clotting factor test, and this is also known as a factor assay. Those are required to diagnose bleeding disorders. The blood test shows the type of hemophilia and the severity, and it is important to know the type and severity to be able to treat. So if you want the best treatment, then you need to have, I always knew this as a factor assay, not as a clotting factor test.
Yeah. Ideally, treatment should be provided at a hemophilia center. You do want a provider that specializes in this condition. Immune tolerance induction is frequent and regular exposure to factor 8 concentrates, often at high doses over the course of several months to years to help build tolerance. After successful ITI, patients are able to restart the use of factor replacement therapies for acute bleeding or even prophylaxis. Some people who infuse with clotting factor concentrates develop an inhibitor. These inhibitors or antibody make it difficult to stop a bleeding episode because they prevent the treatment from working. And there are two types of clotting factor products. You have one that's plasma derived, and plasma is the liquid part of the blood, and it has proteins like antibodies, albumin, and clotting factors. And several factor concentrate treatments are now made from human plasma proteins. The second type is a recombinant factor. In 1992, the US FDA approved this particular concentrate, which does not come from human plasma. Prior to this, the concentrate was made from human plasma, and these concentrates are genetically engineered using DNA technology. That's fascinating.
Mm-hmm. And this is really nice for people that maybe don't want something that's...
There are some religions.
Yes, thank you.
Which,
you knew exactly where I was
yep.
going.
I love this ESP, let me tell you. I love it. So there are some religions in which you cannot partake in any blood products.
Mm-hmm.
And so if you're born into one of these religions and you happen to be a hemophiliac, this is an awesome life-saving treatment that you can take without it conflicting with your beliefs.
Yep. So just to continue a little bit with the treatment options, there are BPAs, which are bypassing agents. These are used to treat bleeding episodes for people with a high titer inhibitor. These medicines bypass the factors that are blocked by the inhibitors to help the body form a natural clot. You will have to monitor closely, though, for unwanted clots when you use these bypassing agents. So as patients who have hemophilia use these different treatments, their body is literally making inhibitors to block the medicine.
Absolutely.
And so sometimes you have to bypass that. That's kind of how I remember that. Coagulation factors or cofactors, these work by replacing the function of factor VIII rather than replacing the missing factor directly. It can be used prophylactically to prevent or reduce the frequency of bleeding episodes in people with hemophilia type A. The one thing to keep in mind with coagulation factors is lab testing for inhibitors are not reliable. Therefore, you would need to do different lab testing to test for inhibitors. Fibrinolysis inhibitors, this prevents clots from breaking down, making for a firmer clot. It's often used for bleeding in the mouth, maybe after you have some type of dental work done, because it blocks a substance found in saliva that breaks down the clots. Vasopressin analogs, these medicines that are similar to a hormone that occurs naturally in the body. The medication releases factor VIII from where it is stored in the body tissue. For people with mild and maybe even moderate hemophilia, these can work to increase a patient's own factor VIII levels so that they don't have to use clotting factors to stop bleeding, which this
That's
would
awesome.
be what I would like
Yeah.
if I had an option.
Yeah.
I would want to take medicine to help my body fix itself, essentially.
There's really no cure for hemophilia.
No.
Unfortunately, to this point, there is not a cure.
Right.
So basically, as a nurse, your considerations would be treatment and just making sure that you're educating your patients on the risk of bleeding and how to prevent the bleeding. Most patients are well aware of their disease and their treatment. This comes from early education, and it's vital. These adults were born with this disorder. They did not happen across it, so they have the education. Pain control related to hemarthrosis or traumatic injuries. You're going to be listening for verbal complaints of pain discomfort. Your patient might tell you that, they're stiff. They have a tingling or aching in an affected joint. They have decreased ability to move that joint. The joints are immobilized for the first 24 to 48 hours after a bleeding episode. They have that guarding behavior in that area, and they're irritable and restless or crying. So this goes for all ages. Like we've said like a million times already, this is a disease that you're born with. So you're just really wanting to, as a nurse, be astute, listen, and support.
Right. And this made me think of, for some reason, sickle cell, where they're having that pain, and I don't think people understand it because there's so many people who don't have it.
Absolutely.
It's not something I would call rare, but it's not very common either. And so I think that this is where listening to your patients and being sympathetic to their pain and their pain levels is important.
Yeah, I mean, as nurses, I think, and even the general, public, I think we all know exactly what hemophilia is.
Mm-hmm.
Every time I hear the word hemophilia, I start thinking of I'm Henry VIII, I am Henry VIII. Okay. Anyway, so we've all heard of it, and we all pretty much know a little bit about it. But as nurses, we just need to make sure that we're being very astute listeners and supporting our patients the best that we can.
As always, we will link our references to our website, thenursingpostpodcast.com. Be sure to subscribe to our podcast on your favorite platform. You can leave us a comment and let us know what you think. Thank you for listening to The Nursing Post.